Yeah, so you have to review her urgently and for the worsening of the sign and symptoms of OHSS. So this has already been told by Dr. Tejashri. Next, please. So when should women with OHSS be admitted? Dr. Varuni.
Ma'am, when the patient is not able to, is vomiting too much, having severe abdominal pain, bloating, unable to tolerate liquids, decreased urinary output is there. And we should not neglect the symptoms, even if there is a slight abdominal pain. She might
Okay.
be, we must be thinking a gastritis is ongoing, but she might be in the
Okay.
OHS as well.
Okay. So all these are the symptoms where you have to consider for inpatient treatment. Next, please. So she should be assessed at least once daily. And if you feel that OHSS is worsening, you have to do more frequent assessments. And analgesia and antiemetics may be used in women with OHSS, avoiding NSAIDs and medicines which are contraindicated in pregnancy. What about the fluid balance? How should you do the fluid balance in this patient who has been admitted in your HTU? Shweta ma'am, Dr. Shweta?
Yeah, I think like someone said that that should be guided by thirst, and obviously the close monitoring. She is a moderate OHSS, so we can give the very close monitoring may be required. Hemo concentration, so hematocrit should be also very closely. Urine output should be very input output charting should be done. Abdominal gut, something very basic, and weight, and also if required involve the other departments, anesthesia input, intravenous colloids, admit the patient if any time we feel that the fluid uh, imbalance is going on, and as highlighted it by the previous speaker, diuretic should be avoided, and of course at the same time I think close monitoring, of course, she is a moderate one, so she may not have, but if she deteriorates, admit the patient and monitor more closely.
Yeah, true.
Close monitoring for urine output also.
Yeah,
Yeah.
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 Mm.
Next, please. So what are the indications for paracentesis?
If patient have discomfort, tense ascites,
Yeah, yeah. So if there is oliguria also,
Yeah.
even
Shortness
after
of breath
adequate
and
volume replacement, then you
yes.
can go
Mm.
for paracentesis, and this can be carried out as an outpatient basis also, right? And it can be done either abdominally or vaginally, but you have to take care that you do not make trauma to the ovaries.
Ovary.
Yeah. Next, please. So this was all about OHSS. Already we have read. Now this is the case 3. Dr. Parul will now take care.
Okay. So this is a 32-year-old woman, PCOS. BMI was 29, AMH 9.2, AFC is 28, underwent IVF due to anovulating infertility. She was stimulated using a antagonist protocol with 150 recombinant FSH and 75 recombinant LH, leading to retrieval of 18 oocytes. After HC, 5 blastocysts were retrieved. A frozen embryo cycle with HRT was performed, resulting in a biochemical pregnancy. At 6 weeks of gestation, she presented with a mild vaginal spotting and a low abdominal discomfort. Transvaginal ultrasound showed gestation sac with a yolk sac, but no visible fetal pole. Serum beta HCG levels were rising, but not doubling. At by 7 weeks, the ultrasound confirmed fetal cardiac activity, but a subchorionic hematoma, measuring 1.5 centimeter, which was noted. She was advised rest and started on progesterone support. At 12 weeks, NT scans showed high resistance flow in both uterine arteries. So, are PCOS patients at high risk of early pregnancy complications and miscarriage after IVF? Dr. Sushmita?
Yeah, PCOS patients, one aspect is the quality of eggs which we retrieve. Now, many of them will have some compromise in the quality of eggs if the PCOS is not properly controlled and then taken for IVF. And apart from that, it is a chronic inflammatory condition along with metabolic syndrome with hyperinsulinemia and hyperandrogenism. All these things will lead to some complication during the first 12 weeks in the form of threatened miscarriage, bleeding, subchorionic hematoma, and they will need extra support during these weeks.
Okay. Dr. Tejashri?
Yes, the PCOS patients are at a high risk of miscarriage and other pregnancy complications for various reasons that Dr. Sushmita ma'am has highlighted. They are having a state of hyperandrogenism, which leads that the elevated testosterone also is said to downregulate the HOXA10 gene expression, which is important for implantation. So that is one important reason.
Yeah, so this has all been discussed. Insulin resistance, metabolic abnormalities, chronic low-grade inflammation, comorbidities like obesity, diabetes, they affect the trophoblast invasion and the placental formation, which hence increases the complication of maternal as well as fetal during the pregnancy. As such, there are two studies which found that there is no increase in miscarriage rate in these patients. But this ASHRAE guidelines say there is an increased risk of miscarriage, higher gestational weight gain, gestational diabetes, hypertension, IUGR, preterm delivery, and a cesarean section. Now, does the type of ovarian stimulation protocol, that is antagonist or agonist, influence pregnancy outcomes in PCOS patients?
Surely,
Anyone
ma'am.
can answer? Yeah.
Minimal stimulation protocol should be followed always in PCOS patient, ma'am. Low dose.
And minimal
Minimal
stimulation.
stimulation protocol.
Yeah, yeah. And
Low
is
dose FSH you should start with.
okay. Anyone else wants to add anything?
To get better rates, LH has a lot of role. So adding LH would give us better oocytes if managed well.
But again,
So
then in the end, we all are using antagonist protocol and
Antagonist,
freeze
yeah.
all. So getting good eggs, of course, is important. And then I think when it comes to IVF, whether we do mild or minimal stimulation, we use antagonist protocol. And then mostly, I think all of us are using freeze all. So
Freeze on, yeah. So as such, there's no significant difference if
uh,
we compare between the antagonist and agonist protocol.
yeah.
But we are using antagonist
Yeah,
protocol
because
in
the
this case.
safety and the OHS has become some
Yeah.
better, more priority than uh, because we have all, I mean, those who have worked earlier, we have
Yeah.
seen very bad OHSs. So, and the patient going into, ICU. So, one has to be safe, and that way,
Yes, yeah.
antagonist with agonist trigger is the safest
The
option.
best, yeah, safest
Best
option.
option, yeah.
Yeah. So does a fresh versus frozen embryo transfer influence the pregnancy outcomes in PCOS?
Yeah, frozen, though we are using, but there are a lot of studies because that may affect the placenta. There is the absence of corpus luteum. So that may have an effect unless we do it on a natural cycle for embryo transfer. So it has been in some studies linked with the placenta problems or even larger babies. But apart
Larger
from
baby.
what PCOS has, the increased miscarriages and diabetes, gestational diabetes, and all problems. So I think this absence of corpus luteum can also be little different for such cases, what we normally do.
So this is a result from a randomized trial which shows that the frozen embryo transfer resulted in increased risk of large for gestation in a singleton pregnancy and a high risk of preeclampsia in a twin pregnancy.
Mhm.
Rest of the complications are same in both the type of transfer. Now, this is a question. Should metformin be continued in early pregnancy for PCOS patients? As we know, we are all using the metformin in PCOS. It should be continued in a pregnancy for PCOS patients or not? Anyone, I mean,
It
all
may
can answer.
it may continued.
It will
This is
continue.
beyond doubt that we have to continue metformin all throughout the pregnancy since PCOS
Okay.
patients, as it is
should be
are at a higher risk of developing gestational diabetes.
Okay. Dr. Anju?
Yes, should continue it.
Dr. Kalyani is, I think she was here. Dr. Varuni?
Ma'am, although I have not continued ever
Okay,
up till 12 or up till 12 weeks, I have continued all
you
the
have
time.
continued.
I have not seen any
Uh,
difference in the live birth rates ever.
Okay, so I will share the evidence. So this is the ASHA guideline in 2023 PCOS. The metformin pregnant women in PCOS have not shown to prevent gestational diabetes, late miscarriage, hypertension, preeclampsia, and macrosomia. But it is considered as some circumstances like risk of preterm birth to reduce a preterm delivery. And this is another meta-analysis which shows the use of metformin throughout the pregnancy. And they have found there's increased possibility of term delivery, reduced risk of early pregnancy loss, preterm labor, pregnancy complications like GDM and a PIH. So there are two types of studies, which one study shows it should be used, another study shows it should not.
There's
Now,
definitely no side effect on the baby. No known. So
no side
that,
effects, and
yeah,
also the
that,
GI side effects of the metformin has not been found to increase in the pregnancy. So it can be
hmm.
continued. Yeah. Now, last question, luteal phase support and early pregnancy support in PCOS patients post IVF. So what do you prefer? Progesterone dose, type and route, and till how many weeks you will continue the luteal phase support?
It may
Anyone can
be in the
answer.
form of gel,
Okay, you are using a gel, fine. Until how
gel
many
or
weeks?
maybe intramuscular injection. And
Intra.
usually we should be given up to 10 weeks, 10 to 11 weeks.
10 weeks. And other panelists can answer. I
I
don't know what
use
they
it till 12 weeks.
12 weeks. Okay. And what
12
is
weeks, ma'am.
12 weeks? Everyone is using 12 weeks.
Yeah.
Yeah.
We are
Okay.
very scared.
Yeah, yeah, obviously. So luteal
Yeah.
phase support, as we know, it improves the pregnancy rate in a woman with PCOS undergoing ART. And obviously, we are using if it is a fresh cycle with any type of trigger, and in frozen cycle also with any of the cycle, natural, modified, and HRT. And what is the reason behind in the case of ovulation, the luteal placental shift does not happen until 8 to 10 weeks of pregnancy. Studies have shown the level of progesterone is 75% at 6 weeks of pregnancy, which reduced to 50% and 25% 10th and 15th week. So production of progesterone by placenta increases significantly after 8 weeks of pregnancy. So the luteal placental shift began at this point. So the luteal phase support were provided until about 10 weeks of pregnancy in the clinical practice. After that time, data shows that ovariectomy indicated that the function of corpus luteum, as we all know, is not necessary for the maintenance of pregnancy. So this is a survey which shows that almost 70% have discontinued progesterone at 10 to 12 weeks. 22% discontinued luteal phase support when heart rate appeared, and 12% when test of SCG was present. It is generally believed that a continuous luteal phase support is better than taking a risk of miscarriage with earlier discontinuation. And there's a meta-analysis which shows that it was unnecessary to continue the progesterone supplementation after first SCG test, but they called for SRT with the RCT with a larger sample size to clarify the duration of luteal phase support after ART. So we should continue the luteal phase support till 10 weeks. So thank you.
Thank.
So so with this,
Thank you so much.
yeah, I would like
Thank
to
you, Dr.
thank.
Parul and Dr. Neelam. It was a excellent panel discussion that we had today. Thank you
Yeah.
for inviting us for
Thank
this.
you.
Thank
So
you,
I
ma'am.
would, yeah,
Yeah, I
thank
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 all the
you. Thanks,
panelists for
Parul.
the valuable input. Yeah.
yeah, I thanks all panelists to have and my moderator, Dr. Neelam, to have a good interactive session in a panel discussion. And I also want to thanks Dr. Neeti for preparing this informative webinar, and Dr. Priya Bhave for collaborating with us with the IFS PCOS, SIG PCOS, and also wants to thank all speakers for giving an amazing talk, and also our mentor, Dr. Mala ma'am, and our audience for patient hearing. Thank you. So I think we can end here.